Good afternoon, everyone. I am Susan Wolford, the Communications and Training Specialist for the Long-Term Care Ombudsman Program. We're glad to have you here today for the first in our 7-part follow-up series of the Trauma-Informed Care. Today, we are going to have communicating with residents and identifying trauma triggers. It is being recorded. It will be available later for people to watch for CEU credit as well, and I will send all that information out. In the next few days, you will all receive certificates for your attendance for this if you requested CE credit. No one participating has video or audio capabilities because of the setup that I have within Zoom. We're in a webinar format. So any questions or comments you have, if you'll make those in the chat, I will monitor those and I'll be sure to let our speaker know. And now, Suzanne Messenger, our State Long-Term Care Ombudsman, will introduce our speaker for communicating with residents and identifying trauma triggers.
Good afternoon, everyone. I hope you'll join me in welcoming Elizabeth Wheeler. Elizabeth Wheeler is currently an RN consultant at LeaderStat. She's an experienced leader in skilled nursing and assisted living, as well as long-term care pharmacy consulting. She's worked in various areas of care, including skilled nursing, subacute rehab, assisted living, memory care, palliative care, and pharmacy. Her main focuses are regulatory compliance, behavioral health, trauma-informed care, infection prevention and control, and quality assurance. Over her career, she's obtained and maintained CMS 5-star ratings and excellent survey results, and assisted many nursing leaders to improve processes and outcomes. As the RN consultant with LeaderStat, her work includes assisted living, in managing day-to-day operations and regulatory compliance, development of plans of correction, guidance and facility preparation for resurvey, education and training, survey recovery, and clinical documentation requirements. Once again, please join me in welcoming Elizabeth. Thank you so much.
Thank you all for joining today. I know it's beautiful here in southeastern Ohio, as I'm sure it is in West Virginia. I really appreciate you taking out time during your lunch hour to talk about a very large topic of trauma-informed care. I know we are all well versed in some of the regulatory changes that took place at the end of October. And since this is such a large topic, we did decide to break down into just chunks so that we can easily digest this information. So today, our main focus will be going over a brief overview of trauma-informed care and what that means, as well as assessment tools, identifying triggers that our residents may be experiencing within our environments, and then also how to communicate with residents to find out what those triggers are throughout their stays. This is expected to be interactive, so please feel free to ask questions in the chat. As Susan mentioned, she'll be monitoring that, and so as we go along, if you do have questions, please don't hesitate to ask. We'll also have a Q&A at the end in case there are any other outstanding questions, so keep that in mind. And just to do a brief overview of the regulatory language surrounding trauma-informed care, and the definition that CMS has determined for trauma is incidents or situations that are considered disturbing, life-threatening, and cause an ongoing disturbance to functioning. Well, that's very broad, and we all experience trauma differently. The regulation goes on to discuss that facilities, as we are all well aware, must ensure that residents who are trauma survivors receive culturally competent, trauma-informed care in accordance with our professional standards of practice. Also making sure that we're accounting for any resident experiences and preferences in order to eliminate or mitigate triggers. So our main focus will be avoiding re-traumatizing residents as it relates to providing TIC. To break down trauma-informed care, the number one principle is safety. So we of course want to keep our residents safe as a team approach, and we'll dig deeper into that here in a few minutes. Also building a trust relationship with our residents and families, and being transparent as we all learn how to provide this type of care. Peer support. I think of the pandemic for sure, for me, and I'm sure most of you, caused a lot of trauma in my life. And so providing support to each other as well as our residents is very important. We can't provide care if our cups are empty. So keep that in mind as well. And then taking a collaborative approach and making sure that everyone from housekeepers, STNAs, all the way to administration are on board with what trauma-informed care means and what the needs of residents are in the facility. Making sure that our staff, residents, and families feel like they have empowerment and a voice and a choice in their care is very important as well. We won't focus much on the cultural, historical, and gender issues that relate to trauma-informed care during this session, but there will be further sessions that dig deeper into that area specifically. So keep that in mind. This is just a focus on triggers and communicating with residents. Safety, so making sure that when we are providing care that our staff and residents feel safe. So a few examples of this would be you admit a resident to the center, they may have a diagnosis of PTSD, social worker hasn't had a chance to do an assessment yet, and at night, STNA goes into the facility to provide care, into the resident room to provide care, and the resident becomes combative. Well, we all have been in this situation. Doctor gets called, maybe a psychotropic medication is ordered, and many of the interaction may have been avoided had we found out that loud noises and being woken up in the night could be a potential trigger for that individual. Addressing concerns with families and visitors is imperative as well. We'll talk about our own experiences and the fact of if I just met Susan last week, do I really want to explain to her the trauma that I've experienced in my life? And our residents are the same. I've never met the social worker before. They go in to make an assessment. Oh, have you had any trauma in life? And the answer is typically no. But as we get to know these residents and their families and other visitors that are coming in, we may determine some other past experiences of these individuals, and making sure that we're maintaining our empathy can be very helpful. Communication and interacting with residents and families throughout their stay, not just by administration or nursing specifically, but nurse aides have the most contact typically with these individuals, and they can be a wealth of information that we can add to plans of care. Making sure that we realize that trauma and triggers are subjective. We all experience these things differently, can help create a safe environment as well. And just maintaining any confidential conversations. Of course, anything that needs to be relayed to the IDT team is documented, but making sure that the resident and families have that trusting relationship with social workers as well as the nurse aides can be helpful. Making sure that resident rights are maintained is very important as well. We want to make sure that we're explaining tasks as we go through ADL care, medication administration, therapy services, and ensuring that any type of secrecy or betrayal are avoided. For most individuals, we may have some residents that are triggered more than others. Again, everyone is unique in their experience. I'm going to move forward and talk a little bit about just basic trauma assessments. I'm not sure what you're all using in your facilities. This is just a basic trauma assessment, and as far as typical traumas that we're seeing within skilled nursing facilities, physical and emotional abuse, neglect, past history of sexual abuse or assault, PTSD related to military service. We obviously take care of many veterans in our communities. Anyone that's experienced a natural disaster. I recently was surprised. I lived in Florida for quite some time and went through a hurricane down there a few years ago, Irma, back in 2017. And I went through it, evacuated with my facility, and I really didn't think much more of it. But this past fall, when Hurricane Ian hit the Fort Myers and Cape Coral area, I was really surprised by my emotional response. Just seeing it on the news, had trouble sleeping. I cried randomly, and I did not realize that I had that trauma still from several years ago. And so, as it relates to our residents, sometimes they'll admit to our facilities. We go through these assessments, ask questions, and they may say, "Oh, I have nothing." But after they've stayed with us for a little while, they may start to have behaviors or some combative experience with staff or refusal of medications, insomnia. And so that should warrant us to dig a little further and discuss what potentially could be causing that from a trauma standpoint. There's a few other things listed here as well. I would like to hear from a few of you. What are some of the traumas that you are having reported from your residents? Susan, if you wouldn't mind, if anyone responds in the chat, if you could read that out.
I'm watching it. We're getting nothing yet, so.
Nothing.
Okay,
Wow.
being abused as a child, loss of a spouse, abuse, neglect, job loss, environmental trauma placed in the nursing home, divorce, domestic violence, previous domestic violence in a marital relationship, past trauma from family, rape, child loss, loss of friends, trauma experienced during active addiction, financial exploitation, and more trauma.
Yeah, thank you guys for sharing that. I was really shocked by the statistics when I was researching for this presentation that 61% of men and 51% of women have experienced at least one trauma in their lifetime. We all experience differently, and I just found those numbers to be astronomical. I'm curious if that statistic will increase given the pandemic. This was pulled from a 2018 study. And so I am curious to see what additional numbers will roll out in the next few years related to our COVID pandemic. We all experience trauma differently, as I mentioned, and making sure that we're discussing these topics with our staff is imperative as well. Oftentimes, residents will open up to nurse aides once they've built a trusting relationship about some experiences, and making sure that your staff feel comfortable not necessarily breaking the confidence with the resident, but sharing with the appropriate individuals of our care teams and our interdisciplinary teams so that we can provide the best care. Do we have many I'm in Ohio, I keep saying STNAs. Do we have many nurse aides on this call?
There were quite a few that registered.
Oh, good. Okay, so I'm hoping that they're on, because you're certainly a huge part of this process, and making sure that you feel comfortable communicating with your nursing leadership, your social workers, your therapists, and making sure that you're sharing the appropriate information with them so that we can update plans of care. So keep that in mind. There are 4 R's as far as trauma-informed care includes, and there will potentially be a test question about this. So if you're unfamiliar with these 4 R's, you might want to jot these down. The first is realization. So what is trauma and how does it impact individuals? And making sure that we are aware as individuals what trauma entails, what can it include, and what to watch for within our residents and our coworkers. 2 would be recognition. So making sure that as we assess for those past traumas, we identify signs and symptoms. Many behaviors that we see in long-term care are directly related to past trauma experiences. So really digging deeper and finding out the root cause of those is imperative. We also want to make sure that we are providing support in grieving processes. I mentioned that the hurricane experience, I was really surprised when I opened up to some colleagues regarding that, how many others had experienced some weather events in their lives and did not recognize it at the time, but further on down the line realized that they did have some trigger responses when there was a tornado siren that would go off or a storm warning. And so just providing support to each other and talking about these things should be normalized. Third is a response. So what do we do with all of this information? We need to incorporate our assessment tools in our policies and procedures, making sure that we are providing training to our staff, updating care plans, and then have an ongoing process of identifying triggers. At the end of this presentation, we'll briefly talk about QAPI, our QA processes, and how to format our trauma assessments and programs into our QAPI documentation. And then fourth is resisting re-traumatization. So of course, with many assessments, as you know, they're quarterly assessments geared towards the MDS. Trauma assessments are not the same. We do not want to re-traumatize our residents by asking if they've had trauma every quarter. We do, however, want to make sure that we are monitoring upon admission, asking those questions, and then any changes in behavior, changes in medications, or any additional changes in condition that could warrant a reassessment of trauma. Being careful not to label people by their diagnoses is very important, specifically PTSD. I know if you're familiar with, I know not all of you are, but you are familiar with CMS Form 802 or that matrix. They've added a column regarding PTSD and trauma. And so I just need to be cautious about not identifying individuals specifically by their diagnoses. Also, making sure that we avoid arguing or criticizing residents or making them feel guilty in any way or shameful. An example of this would be a resident that is being combative and saying something along the lines of, "Oh, here she goes again," or here he goes again, let me go get the nurse, and just being more empathetic in those situations. And we'll talk more in detail about this in a few minutes. Does anyone have any questions so far?
Nothing showing up.
Okay. All right, we will continue moving forward then. Contributing factors. We know that our residents have complex health conditions that could warrant trauma responses. We have behavioral health concerns that we're caring for in our facilities. We also are seeing developmental and cognitive impairment within centers. And so communicating with those individuals sometimes can fall on the family. So we need to make sure that we're including those people in these conversations. conversations. Psychosocial barriers. Someone mentioned earlier when we were talking about traumas that we're seeing substance abuse. Many people are hesitant to talk about their past history with substance abuse. They may be fearful of sharing that information with a facility, fear of labeling, fear of judgment, fear of shame. And so keep that in mind as well. And then communication is certainly something that needs to be augmented based on the resident as well. And we'll talk about some techniques in a few minutes. Some other challenges to care and things that contribute to trauma, homelessness. We're seeing that throughout the Midwest, the East Coast, West Virginia specifically. I've spent many weeks. I recognize some of your names. I'm sure we've crossed paths, but I was very surprised by the homelessness that's experienced by some of our new residents. I have been seeing more and more referrals that outline homelessness as well. So we need to keep that in mind as a potential trauma. Food insecurity. You know, I'm sure you're all aware of the price of eggs right now and many other staple items. And so anyone that's experienced food insecurity in their past may be triggered within a facility with a delayed meal tray delivery, or if they may ask for a snack, if there's a delay in getting that snack, or instant response of, oh, we don't have that right now. And we do see some behaviors come around that. And again, the root cause can be a history of food insecurity. Substance abuse, I mentioned that earlier. We definitely need to try and remove the stigma. We're all dealing with this in our community in one way or another. Hard pressed to find someone that doesn't know someone that suffers from the effects of substance abuse, whether it's a family member, a friend, a coworker. And so we need to be aware of this aspect. Family dynamics and strained relationships. Financial insecurity is another. And then loss of identity. You know, when I was making this PowerPoint, I was thinking to myself, how much of my identity is my job? How about you guys? What are some of the things that make you, you?
We do have a question. It
Yeah.
says, I heard you say that we don't want to do trauma or PTSD screening quarterly. Are we required to screen annually or just upon admission?
We are required. That's a very good question. So you are not required to review annually. You do have to screen upon admission. And then with any behavioral changes, it's recommended. Medication changes, specifically related to a change in behavior, depression, if they're triggering, you know, on PHQ-9, that could potentially cause you to do an additional assessment of trauma. We will go over this in a little more detail on another slide, but those are the major requirements. There are a few other examples that we'll go over. Okay, so back to identity. I want you to think about what is the one thing that you identify with. Like I shared with you that mine is my career. And if I were unable to work, I would be at a loss of what I would be, you know, what makes me me. So what are some of the other things that you all identify with?
My family.
Family. Anybody else?
Church.
Church.
Being a mother and grandmother. Spousal status. Parent, sibling. My gender identity. Art. I would be lost without people in general. Talent and abilities. My faith and family. Being a mom, good friends.
Yeah, Those are all so important. And I want you to place yourselves in the shoes or beds, if you will, of the resident. I'm a new admission. I come in and I don't have my family. They may have augmented visiting hours. They technically can come anytime, but they usually only come, once a week to come and see me. Church services, I can't physically go to my church, but I saw on an activities calendar that they do have a church service on Sunday, but I'm not sure how I'm going to get down there because I can't get out of bed yet. So those are just some thoughts that may be going through their heads. Somebody mentioned their gender identity, and we'll talk, we have a session in June that will talk specifically about cultural and gender identities, and that it's definitely something that can result, in feeling dehumanized in healthcare. We're all we become a number, a room number, and we lose ourselves. And then someone mentioned art. Activities obviously are very important, and making sure that we identify these residents as they come in about what their preferences are, and making sure that if their true identity is attached to art, that we're making sure that those activities are available to them. Okay, so what is trauma, and how do we determine each resident's trauma? And ultimately, how can we help? This is a large question that can be very challenging to answer. What does trauma mean to you? There are no wrong answers. We talked about types of trauma, but what does trauma mean to you? What's the first thing that comes to your mind?
Needing support.
Needing support.
How it
Anyone else?
affects someone, feeling of helplessness.
Helplessness.
It's running up the screen quickly. Difficulty dealing with emotions. Something outside the normal expectation of life that impacts you socially, emotionally, and physically. Feeling lost and alone.
Lost and alone. Absolutely. And
unable to move forward from that experience.
Unable to move forward. Thank you for sharing that. And we need to figure out how residents are experiencing trauma within our facilities. And in order to do that, we need to allow them to open up to us. One way to do this is to determine what event has occurred in their life and what experience they felt during that time. But most importantly, what ongoing response are they having? What ongoing stress? Are they having insomnia? Are they jumping when they hear the housekeeping cart or that wobbly vitals cart come down the hallway? I am sitting in a resident room at a facility right now, and before the presentation started, I closed the door and I was listening, and all these sounds. There's beeping, there's fans going off, there's cars honking, there's laughter, and there's just so many overwhelming sounds. And for someone that has been through a traumatic event that is anxiety inducing, when they hear a large amount of sounds, I believe our facilities aren't necessarily the best environment or it's not conducive for reducing that. And so keep that in mind. Someone had asked about the specifics for when these assessments. This is the slide that I was referring to. And so if they do trigger for a SIG change, certainly do a trauma assessment. If there is a irregularity found by the pharmacist with medications. That's another example of something that may trigger, specifically with psychotropic medications. If you are using PRN psychotropic medications, obviously the 14-day stop date for review is in line here, but it would be a good idea to complete a trauma assessment at that time as well. I'll leave. Susan, you're sending these slides to them?
Yes, I will be sending the slides to them with the recording. There's a question that has popped up that said, where is this information coming from? Not seeing this in interpretive guidelines for trauma.
Well, that's a very good question, because it is not in the interpretive guidelines. There is a resource page at the end of this PowerPoint. Some of this does come from CMS, some comes from SAMHSA, and those are the major sources. As far as the interpreted guidelines, when trauma assessments should be done, these are suggestions. The interpretive guidelines currently indicate that upon admission and with significant changes, a trauma assessment should be completed. That is what the current guidance says.
Follow-up question says, so how are we as facilities to know what we are supposed to be doing to address trauma?
Can you be more specific? Address trauma and as a whole, as a process, or individual? That's a very broad question.
Guidance as far as assessments and screenings.
Okay, so as far as what needs to be done, an assessment needs to be completed upon admission, and with any SIG change that would be triggered on the MDS. It is also, that's what's required. What is recommended is that you also complete with any newer recurrent symptoms, behavior related. For example, if you have a resident that's suddenly experiencing insomnia in your building, that should warrant additional discussion by a social worker, a nurse, discussion with a family, what might the root cause be of that particular issue. Does that help answer your question?
Nothing more from her yet, but the next question is, the admission process is overwhelming for resident and family. How do we incorporate this assessment when we do an initial social service assessment?
That's a very good question. I would recommend not going in as soon as the resident admits. We do have the window of time to complete those admission assessments, and so certainly during your initial conversations with the residents, building a rapport is the best option I have seen, and just building trust with them, going over your assessments that need to be done, whether it's your BIMS, your PHQ-9, your discharge processes, and then asking them specifically if they have any past traumatic events that they would like to share. Specifically, based on that trauma, what can we do as a team to prevent you from being re-traumatized, which is what we're about to go over. And so that is, to me, the best process. Certainly, if anyone on the call that has been completing trauma assessments has any thing that they would like to share, please feel free.
Nothing popping up right now.
All right, okay, we'll keep moving on then. So based on your trauma assessment, oftentimes the residents will say that they have no trauma and they don't have any triggers, and that's where it ends. And Then weeks go by and we start seeing some concerns. Might look like, oh, the nurse aide reported last night that the resident became combative when we attempted to give a shower. The nurse called the doctor and they ordered PRN Seroquel, and they'll be in to see them today. That's actually an example that happened last week that I was involved in. And one thing that we found drilling down and doing a root cause analysis was contacting the family and finding out that this individual almost drowned when she was younger. She does have dementia at this time. And had they had that conversation with the family, they may have identified that just seeing the whirlpool tub in the shower room was enough for her to be triggered and become combative. And so when I talked with the nurse aides regarding this situation, it came to light that this individual had shared with several nurse aides, even though she did have some cognitive decline, that she had almost drowned in a bathtub when she was a teenager, and that she was very fearful. She did not want a bath. She didn't just want a bed bath. She wanted to feel clean, but she was very concerned about being placed in a tub. That communication just never went from the nurse aide to the IDT team. And so communication is imperative if we're going to be able to provide care without triggering individuals. Another example would be loud noises. So residents admitted for rehab, had a hip replacement, has been screaming out in the night. Numerous grievances from other residents and families regarding this individual. Look at the initial trauma assessment, says no trauma, no triggers. However, with an interview with the family, it was determined that this individual was in fact a veteran and had not shared that with the social worker during the initial assessment, and had been very vocal at home anytime there was a garbage truck outside in the early morning hours, or a neighbor making a loud noise next door, very jumpy. And so some of these things may come after admission. And so don't be afraid to reassess and update your care plans and your assessments on an ongoing basis. The regulatory language has allowed for us to meet a requirement, but also give us flexibility and when to do these things. I challenge you to look at these trauma assessments not so much as a checkbox that needs to be done, but a tool to determine how we can provide the best care to our residents and our staff members.
A couple of comments about stuff. Usually nursing will do some type of trauma assessment upon admission. It may be called PTSD assessment. Depending on your setup, there will be a separate assessment or it is incorporated in with the admission assessment. And another one says they provide the families with a life story to be completed. And one of the questions is, are there any life traumas or losses the team should be aware of?
I like that life story idea. That's great. Thank you for sharing that.
Nursing often skips over this because they are uncomfortable to talk about it. Another says they have found residents may be unaware or deny their trauma or triggers. And yeah, it says the life story again. So
yeah, absolutely. And those are all barriers that we are dealing with. And building rapport with residents and trying to identify some of these things is very important, but also focusing with our staff, specifically nurses and nurse aides, and talking about trauma. What does trauma mean? You know, how would you all feel if someone walked into your hospital room or your skilled nursing facility room? You've never met them before. They sit down with a clipboard or a laptop and say, have you ever experienced a trauma in your life? I would be curious to see how many of you would feel comfortable immediately opening up to that individual. I don't think I would. And so it's all an approach, and how can we communicate? How can we communicate with our residents and try and figure out some of these things? So verbal and nonverbal communication is very important. Building relationships, watching people's body language, making sure that we're asking open-ended questions, not just reading off of our assessment tool. Have you experienced divorce? Yes or no? Have you experienced homelessness? Yes or no? And trying a different approach of Mrs. Jones, it's really beautiful out today. Would you like to go sit in the courtyard with me? And maybe taking the resident outside and just talking about the weather, pointing out some birds, and building that relationship before approaching the subject of trauma. You would be surprised how much information they're willing to share once they've built a little bit of a relationship. Active listening as well. I keep harping on the nurse aide relationship with residents because it's so very important. And just listening during care, whether someone shares during peri-care that they had experienced sexual abuse in the past. They may never have said that to the social worker, but that is something that should be shared with a social worker by the nurse aide. Certainly not breaking trust, but so that we can provide the most appropriate care to the resident. And then also touching someone's shoulder if they're comfortable with that. Smiling, making direct eye contact, sharing a meal. I noticed last week I was at a facility where one of the nurses, I don't know how they found time for this, but they did. they did eat lunch with one of the residents that had recently admitted, and it was really heartwarming to see them communicate and just build that relationship over a meal. And so there's not a right or wrong way to do this, but do challenge yourselves to take a different approach with your communication as opposed to being task oriented and reading your assessment tool to residents. What does the word trigger mean to you? Think about that and feel free to share in the chat. Triggers can be a smell, a sound, a person. I always like to share about when I was first a nurse. I had a dementia resident on my rehab unit, and he tried to strangle me with my stethoscope when I leaned over him to do an assessment. And I was very taken aback. Obviously, everything worked out. I'm still here. But when his daughter came in and she saw me, she immediately said, "Oh my goodness, you look just like so-and-so." It was a granddaughter that had stolen money from this resident in the past. And during our encounter in his dementia diagnosis, he obviously had thought I was her. And so that's another example, an extreme one, but something that was a trigger. I was a trigger as an individual for him. So
you're getting a variety of responses about words or phrases or smells or events that take you back to an uncomfortable situation.
Great. Yeah, that's absolutely right. And it's important that we understand triggers so that we can understand what could potentially trigger a resident. And so when we ask the question on our assessment tools to a family or the resident, what do you have any triggers? Often we say, what we want to provide care for you to the best of our ability. What can we do differently? And that can get us some answers, as opposed to simply asking, do you have any triggers? That word is not necessarily something that our geriatric population is familiar with. It's also not something that our younger residents may feel comfortable sharing immediately, especially if they don't realize what their triggers are yet. And so we do need to monitor that throughout the stay. Some other triggers could be loneliness and vulnerability. During day shift, people come in and out of resident rooms throughout the day, and then that evening comes, and after that medication pass, it can get lonely. And so making sure that we are checking on individuals that would like to have conversations in the evening hours, and things of that nature need to be accounted for. Pain and muscle tension. So this is something I found interesting when I was researching this. We're so focused on pain management, and there's numerous regulatory updates regarding pain management, but tying a trauma in with increased pain, muscle tension can be something to consider as well when you're interviewing and doing a pain assessment on residents. Psychosomatic situations, if you do have psych services or counseling services available in your facility, they can certainly be helpful in identifying some of these concerns. Dismissiveness. I turn my call light on, somebody comes in, asks me what I need, they shut it off and walk back out. That can incite some anger, especially if my need is not being met. And disrespect, certainly we want all of our staff members to be respectful, but some behavior, lack of eye contact, not communicating medication changes, treatment changes, discharge planning can all be signs of disrespect, and can certainly be a trigger for certain individuals as well. We talked a little bit about sexual abuse triggers, specifically with bathing, dressing, bathing, basic ADLs. We may see, especially in demented residents or developmentally delayed individuals, anyone with cognitive decline, we may see some combative behavior or resistive to care, refusal of care. And so as IDT teams, I do challenge you to dig deeper into what could be causing those types of behaviors, and not necessarily attempt medication management. Non-pharmacological interventions obviously are a focus, but really drilling down in what the root cause of that behavior could be, and incorporating discussions with families to determine if sexual abuse has occurred in the past can be appropriate as well. Has anyone struggled with this in your facility? Combative residents, refusal of showers, things of that nature? I'd be surprised if anyone didn't.
Yes, there's answers starting to pop up now as to yes.
Exactly. So it's everywhere. And so just keep that in mind. If you have not assessed individuals for past abuse and they've had a change, they're becoming more combative during care, do consider reviewing that and ensuring that you've determined if that has occurred.
There's one point here that says my residents will only let certain age shower and change them.
Mm-hmm. And that is a very loaded situation. So we all have preferences. Mary might do it differently than Jane, and John might do my nails after my hair's done. And so there's preferences, and then there's triggers. And so identifying why the resident likes certain individuals to care for them over others is where I would go with that, so that we can all try and provide care. And again, if you do identify someone that a staff member that is re-triggering or re-traumatizing for a resident, augmenting assignments and things might be necessary, not to the fault of anyone, but certainly, you know, if it's determined that they look like someone that has hurt them in the past, you need to revisit that and on an individual basis. Some other barriers, we already talked about being task oriented, but not tapping into all team members. I mentioned nurse aides being in rooms and really finding out information from residents, but housekeepers too, maintenance men and women seem to know a lot about residents that we don't always discuss and add into care plans. So definitely tap into those members as well. Discussions with families, we mentioned, make sure that you incorporate them in your assessments, and then monitoring for burnout. You mentioned nurses, someone mentioned nurses doing assessments and being uncomfortable with discussing trauma and not just skipping over that part. Part of that can be education, but another part can just be they're overwhelmed with all of the other aspects of the admission assessment. And so I could do a whole presentation on burnout, but certainly be monitoring for that in your staff as well. Ultimately, once we determine what these triggers are, we need to update care plans and ensure that the trauma has been identified in the resident's care plan, and that the goals that are developed are focused on resisting that re-traumatization, making sure that any interventions, whether it be reduce noise, female caregivers only, showers, no whirlpool tubs, all of those types of interventions are communicated to the entire care team, so that we're not having a housekeeper, I've just used this as an example, housekeeper using a really loud cart outside a resident's room. Maybe we need to look at that cart and see if we can fix it, so that we're not triggering any type of behaviors. Making sure that in addition to nursing and social services, that activities is involved. Someone mentioned that art is a huge part of their identity, making sure that that information is incorporated into the activities care plan, and appropriate engagement is provided. Therapy, you'll be amazed what residents will tell physical and occupational therapists, speech therapists too, and so making sure that they feel comfortable bringing that information to the IDT team. And then dietary, of course, some individuals are sitting in their rooms, eating. That can be very isolating. If we've identified that's their preference, of course, that's okay. But if they have suffered from trauma where isolation is a re-traumatization for them, we need to be encouraging them to get out to dining areas, communal dining, and eating with other individuals. And then also making sure that staff development is focused on behavioral health and trauma informed care and delivery. For QAPI services, so we all love QAPI, and it's a very intricate process. But as far as trauma-informed care goes, focusing on individual assessments can be important. If you've identified a resident that has PTSD, don't be afraid to incorporate what processes you're doing, what changes you're doing for that particular individual in your QAPI. Also make sure that you're updating your facility assessment on an ongoing basis to identify individuals that have trauma in your facility, specifically, PTSD. If you have individuals that you've identified have a past history of sexual, physical, emotional abuse, you definitely need to add that into your demographics as well. And so, has anyone started, or do you feel like you have a successful process of incorporating trauma-informed care in your QA that you'd like to share? Susan, is anyone responding?
Nothing popping up yet.
Okay. If you do determine gaps in care, for example, if you admit a resident that has increased behaviors after they've admitted, and you've identified that staff member or a certain gender of staff member is triggering for them, I would include that in your QA processes. If anyone has any questions on how to do that, I'm happy to go in further detail. No? Okay. Well, that was a lot of information to cram into an hour. Does anyone have any specific questions about what we went over, or if there's anything unrelated to the topic that we discussed, but related to trauma-informed care in general, feel free to ask.
While I'll wait to see if anything else comes up, there was a question that was asked, again, going back to the assessment. I am not seeing anything in interpretive guidelines specifically addressing admission and significant trauma assessments. Am I missing something?
If you'd like, I can pull the current F699 guidance. And Susan, if you get that individual's information, I'm happy to send the information.
I certainly will.
Anyone else? Any comments, questions, challenges, barriers that you're having with identifying? Okay. Well, if you do, feel free to email Susan any questions that you do have. We will go further into interventions as well as tactics for eliminating re-traumatization on our next section. Again, this is strictly focused on communication, so there is definitely more to this topic that we need to discuss. Thank you.
Thank you. I'm going to, there was something that just popped up and I missed it. Yes, I'm going to share all the information with you that with the slides, and the recording will be shared later, and anything that Liz sends me based on that guidance that we were just speaking of, I'll send that out to everyone as well.
Wonderful.
There, again, this has been recorded. It will be shared with you, and the slides later this week. You will all receive your certificates if you requested CEs for this. If you are an activity director person receiving CEs for this, you will get an email with a post-webinar test that you have to complete, and the evaluation should pop up at the end of the meeting. And we ask that everyone complete that so we can, do better every time we do another session. And in the webinar chat, I have put up the link for the evaluation as well.
Wonderful.
Any other questions? Suzanne, anything you'd like to add?
Don't really have anything to add, but I wondered, would you mind to give folks a sneak peek at what they could expect next month?
Oh, thank you. I'm glad you said that. I apologize. Next month, you will be receiving in the mail, if I could get an email, a link to next month's presentation registration, which will be interventions and responses in difficult trauma situations. So again, next month, March the 15th, the third Wednesday of the month, we'll be offering another webinar, interventions and responses in difficult trauma situations. And that registration information will be forthcoming. And that will again be Elizabeth Wheeler doing that presentation.
Yep.
Oh, okay. Something's going on with the evaluation
I
for some
know,
reason.
I see.
I will send the link. It will come in the email because I'm not sure what's going on with that link. I just copied it straight out of that. But when we close the webinar, it should pop up for you as well. And otherwise, that will be an email that you'll receive later today or tomorrow.
Awesome.
Thank you, Liz.
All
Thank
right,
everyone
thank
for
you,
joining
guys.
me. If you have any other questions or comments, please feel free to email me. Thank you so much.
Thank you,
Bye.
guys. Have a good day.
Thanks, everyone. Have a great afternoon.